So, without wasting much more time, the first speaker we've got today is Simon Carley, Professor Simon Carley. Now, if you haven't heard his name, you probably should have. He is massive in education. The St Emlyn's podcast, ATAC, are to name just a couple of the things that he's involved in. He's an emergency and pre-hospital care physician from the northwest of England. And what he's going to do today is start to set the scene for the sort of things we'll be talking about this week.
And that's a bit better, isn't it? I'm not quite so turned on now. Fine, but what I want to try and do is leave you with questions. Now, you do not need to take any pictures or anything of that, or you don't really need to listen to the detail. It's all available on the St Emlyn's website. There's a QR code here. I'll put it up again at the end. You can find it very easily. And that's got all the background critical appraisals, all the links to the papers, and everything else that you want to know. Because if you're good, you want to go away and question my opinions, because I'm going to give you my opinion, and you won't agree with everything that I say, and that's okay. So looking back at the last year, what have we got? I've kind of got some themes that I found in the literature really, and the first is around major bleeding. So let's have a look at some of the papers that have been knocking around this year. The first, I'm sure you've seen this one, was the UK REBOA trial, came out last year. Ooh, grumblings in the background. Very interesting trial. I have some pecuniary interest, not pecuniary interest, but I have some interest in this right from the beginning, even when it was originally mooted. It was interesting because it was a trial of REBOA. You all know what REBOA is. And it was done in the UK. 16 UK major trauma centres were involved. They took patients over the age of 16. They thought they were exsanguinating from bleeding in the lower limbs or the lower part of the body, and they randomised them to either REBOA or not REBOA, and they looked at all-cause 90-day mortality. In our, first look, there's nothing really wrong with that, apart from maybe in the wrong place, but it's nothing really wrong in terms of the design. It's an RCT, it puts people in it, they are the right kind of patients in the emergency department. Interestingly though, and perhaps not what the original plan of the authors was, it was stopped early because there was increased mortality in the group of patients who got the REBOA. But there was also more time in the ED, and there were also more complications. It didn't really do what they thought it was going to do at all. And there's been lots of debate about this, lots of sort of interest in why that might be, because there are certainly aficionados of REBOA around the world, and there does seem to be observational evidence that it can work in some patients, and it almost certainly does. Like a lot of the interventions we're going to be thinking about today, case selection is really important. But in this particular study, doing this in the emergency department at an average of about 90 minutes after the point of injury, that ain't exsanguinating hemorrhage for me. It's too late, and those aren't the patients who are actively bleeding to death in front of you, who might be the ones who might, because we don't know because we've not got the data, be the ones who might benefit. So is REBOA dead as it balloon popped? Probably in the emergency department after long delays. The evidence is that it's not a good thing to do, get them to theatre. But for other areas and other sort of indications, maybe not. And that's the sort of question that this conference needs to have. Let's go for another trial from the UK. Let's talk about CRYOSTAT-2. Is another interesting study which perhaps didn't show us what we thought it was going to show. This is a trial of cryoprecipitate, so 3 pools of cryo in severely injured patients across 26 multi-centre international studies. It's an RCT. It's what we want to see. It was open, so people knew whether they were going to get cryo or not. We recruited for this in my department. And they looked at all-cause 28-day mortality. Go and have a look at the massive details on the website. But it's the basic design is pretty sound. It's not a bad way of looking at an intervention. Interesting, what they found is no difference. And this was a bit of a surprise because on previous work, observational data and looking at what happens to coagulopathy in patients who come in with major trauma and the acute traumatic coagulopathies, there's an expectation this might make a difference. It didn't. And there's a couple of other papers that are heading in the same direction here, because this is basically giving cryoprecipitate to people on the ones that you think might have a problem, but you don't know they've got a problem yet. Really interestingly, if you dig into it in a bit more detail, there's some really good webinars and seminars and some good stuff from people like Karen Brohy you can follow on Twitter, delving into cryostat in a bit more, and Ross Davenport, who was two of the lead authors. Ross Davenport was the lead author. If you actually looked at the difference, this wasn't what I was expecting to find at all. So if you looked overall, there was no difference. But if you looked at the blunt versus the penetrating, it was actually kind of the opposite, which I thought would happen. So the penetrating patients, the one who I often see clinically, are the ones who are bleeding and they're continuing to bleed and bleed and bleed, versus the blunt patients who have often bled but then have stopped. It was actually the blunt patients who appeared to have a better outcome. I can't quite explain that. There's a lot of debate, and those are the things we need to think about. We've seen some really strange stuff with recent trials about bleeding, where we've seen unexpected groups in the, and they are sub-analysis, so they're hypothesis generating, they're not definitive, but certain groups of patients who we think, why is it that, in the Pamper trial, why was it that the head injuries got better outcomes than the non-head injuries? And things like that. So we're seeing these strange things around coagulopathy which we don't quite understand. And the head injury thing may be a factor in the Cryostat-2 trial. I thought I'd start a fight, so hopefully there's somebody here from North America, so we may as well talk about TXA. So TXA is tranexamic acid, as you know. There were studies all over the place. We've had CRASH2, CRASH3, MATTERS, lots of studies which have suggested that there's a mortality benefit from bleeding outcomes in TXA. However, there were valid criticisms of a number of those trials, particularly that they weren't done in mature, efficient, high-quality major trauma centres. So this is a really good trial that was done in the Antipodes largely, looking at whether or not it made a difference to patients who are expected or presumed to have the likelihood of a traumatic coagulopathy. So they took a group of patients who they thought were going to be sick, and they were sick. They used something called COAST scoring to determine whether or not they were going to be likely to get a major hemorrhage pack required. So not bad. 1,300 patients is a decent sized trial. It's not massive, but it's a decent sized trial. They looked at TXA versus placebo, and they looked as an outcome at the modified Rankin score, which is a functional score at 6 months. Now, generally speaking, I kind of like functional scores because that's what patients really value. But there was some debate about whether that was the right outcome. And actually, I think it's reasonable. So let's have a look at what they found. Their differentiation between what was good and a bad outcome was between a modified Rankin scale, between the green and the yellow here, between an upper severe disability and a lower moderate disability. And if you take that line, you can see the dotted line here, there's no difference. So at 6 months in terms of modified Rankin scale, according to the value that they took, there is no difference. There's actually more survivors. So if you look, there's more survivors, but the survivors are in the lower severe disability group. Perhaps not surprising that if you've got a drug which makes a few more people live, then there may be those are the ones on the margins, and they may have more disability. That's perhaps not a surprise. There's also debate about, and there has been debated about whether or not a 6-month outcome in functional outcome is the right measure for something which is designed to reduce death from bleeding. But that's open for debate. If you delve into the data a bit more, then certainly outcomes of survival were better at 24 hours and at 28 days. And those kind of numbers and those kind of differences are consistent with what we've seen in a lot of other TXA trials. So it does seem that around about 1.5 to 2% improved mortality wherever you look in whatever the trials. No particular difference in DVTs. So I don't know, take away from it, TXA is a highly emotional drug for some reason. I don't really know why. But if you want your patients to live, give them TXA and then you hand them over to rehab and see if they can work out what to do. But actually, in order for rehab to get better, the patient's got to survive. So it's on the step. Anyway, those are the big ones I wanted to talk about. Let's talk about some honourable mentions in the bleeding category. I feel like the Oscars now. There's a really nice paper from London which has got a really interesting message looking at the identification of severe hemorrhage. So these are patients who are major trauma patients, and are we as clinicians able to spot whether they're going to require a major hemorrhage pack or maybe a hemorrhage protocol? And actually we're not bad. We spot it about 70% of the time. And when we spot it, so sensitivity of 70%, specificity of 94%. So if we say that they definitely need it, we're probably right. But we miss quite a few. That's okay, I suppose. But the really interesting point in this is the ones that we miss have got triple the mortality. So there's something about you and me, about making the decisions, which is really important in the outcomes of these patients. Because the MHP is the MHP. The decision about whether to give it is you and me. And that's in our brains. So this is an area where we think we need to maybe a bit more research and a bit more help and support about decision making. So what about scores? So we've got things like the which was looked at this year, and you may be familiar with other scores like the ABC score and shock index and Gestalt to decide whether or not somebody needs a major hemorrhage pack. The RABT score performed as well as all the others, and it's also shite. So it's pretty good, but it's not as good as it needs to be for us to spot that group of patients who we're missing who have triple the mortality. So there's work to be done there. That's really interesting and good work. And I really like this very small qualitative study from, again, from the UK Air Ambulance, where they took really experienced clinicians about what makes them decide to give blood to patients in the pre-hospital area who they think are shocked and bleeding out. And that was really interesting. What actually do people use as decision-making tools? And what came out of that is they used something called recognition prime decision making. This is from the work of Gary Klein. If you've ever read Streetlights and Shadows, great book. Scott Weingart talks about it a lot. What they're doing is they're using pattern, so to a degree pattern recognition, but also this ability to model in their head what's going to happen with all the different variables about how sick the patient is, who the patient is, what the injuries are likely to be, where am I going, all of those things coming together. The bottom line is that complexity, uncertainty and judgment are really important in the management of the bleeding patient. And that's about us as much as is about which drug do we give and does it work in a randomized controlled trial, or does REBOA work, yes or no? That's the big thing I want to take away. A couple of other mentions in there. Top Art was a small RCT looking at artesunate, a malarial drug, had promising stuff in laboratory work, didn't work, but it was a small trial and a significant increase in DVTs in that for some reason which we don't really understand at the moment. ProCoag was a RCT of 4-factor prothrombin complex concentrate. Again, done a bit like the cryostat thing, so they just gave it to everybody, an RCT, and it didn't work either way. And again, the outcome from both of those and from in general about these extra bits that we're putting onto coagulopathy is we maybe need to have some numbers and some data to decide who needs it and who doesn't. But of course, if you with longer memories, remember iTactic, which came out the year before, which is where we did exactly that. We did ROTEM and TEG to decide what we would give to patients and judge it on the facts, and that didn't so benefit either, although perhaps it did for the brain injured patients. Subgroup analysis, hypothesis generating. Isn't it interesting? We know loads more, and we seem to know less. Fantastic. So let's talk about airway and breathing now. These are some more, a little bit more general type stuff, a little bit more interesting practicality type stuff. There's a nice paper looking at emergency department operating intubation, whether you intubate your major trauma patients who are bleeding and require urgent hemorrhage control, whether you intubate them in the emergency department or the operating room. You think, well, that's not that exciting. But as always, there's a message in here which is a bit more interesting. So what they did is they took 253 US MTCs, loads of data. And they looked at those patients who required early hemorrhage control, so those are the ones getting to theatre within 90 minutes. So these are sick patients, probably a lot of penetrating patients. It is retrospective, all the problems are retrospective data, but it's interesting. Logistic regression, and they looked for mainly in-hospital mortality, but also what people were doing and what perhaps their decision-making processes were. 9,667 patients, of which 20% got intubated in ED. Everything was worse if you intubated them in the ED. They died more often, they had more complications, everything went wrong. And that fits with what I know, because I mean, my life in anaesthesia when it was, before I went into emergency medicine, was for things like an aneurysm, you don't anaesthetise a patient until you can see the whites of the surgeon's eyes, and they're stood next to you and the patient's on the table and ready to go. And that's been my mantra, and that's what I've been taught in pre-hospital care as well. You know, you really don't want to put your penetrating, hypertensive, shocked patient who's still just about talking to you. You don't really want to give them an anaesthetic right now, unless you absolutely have to, because they're going to try and die on you very quickly, and they don't need your help. So, the thing about this is they go, oh, maybe it's just a case mix. You know, there are those patients who are so sick, you've just got to do it. And I accept that. So what they did is then jumped in and said, well, what is this about the patient characteristics? And so they looked at the patient characteristics, and they could not find this. They found wide variation in practice between units, but they could not see this from the patient data. So the feeling is, my interpretation, and there's an excuse at the end of this for what I'm going to tell you, is there's two universal indications for every procedure in medicine. You can think of any procedure in medicine, and they've all got two indications. One, the patient requires it, and two, you really want to do it. And only one of these is actually okay. And it reminds me, always I like to put a slide of John Hines in, because he's a hero of mine and ours. And he always asks, you know, when you're doing practical procedures, are your intentions honourable? And there is something about, if you teach emergency physicians, and I am an emergency physician, to intubate people, we really do quite like to do it. But you know what? Sometimes we shouldn't. So let's have a think about that. Again, judgment, uncertainty, and complexity. So that's an interesting one. Go away and have a think. Have a look at your own data when you go back. Let's talk about VL versus DL. Oh, this is going on forever. Started at SMAC Conference 1, 2019. I remember talking about 2009. It was a long time ago, 2013. There was a debate about it then. I think we're getting to the point now where we're learning a little bit more about what the data is around VL versus DL, video versus direct laryngoscopy in the critically ill patients. So this is a nice RCT, 17 emergency departments in the US looking at ED intubation, and they predominantly looked at first pass success as a marker. Now, interestingly, as an aside, There is a nice paper this year that shows that first-pass success in a mature system that works well is not correlated with patient outcome. And so arguably first-pass success, which is pretty much in absolutely every bloody airway trial everywhere, may not actually be a good outcome measure. So we'll park that for a second and we'll go with this. Because what they found is that their first-pass success, or their achievement of getting the tube in, was this. And two things: it was better with video. It's not very good. So these success rates are not what I would accept in our service. And that's probably, and it is, because they were in the teaching departments where they were allowing people to learn. And if you looked again in a bit more detail about, does it make a difference between VL, DL if you're an experienced intubator? So if you've done more than 100 down here, so on the right side of the line here, it's an advantage if you are using VL. Over 100 intubations in the past, it doesn't make any difference really, not statistically. What does this mean? It means for me, two things. One, if I'm teaching, I can teach people how to use it. I can coach them. It's really, really good from that perspective. And pre-hospitally, if I'm using VL and I've got a critical care paramedic with me, they can see what's going on. They can anticipate what I'm doing or can work together. But actually, getting the tube in is not the major thing. And maybe we should be looking at a different way about outcomes in these trials. Hypertension, hypoxia, cardiac arrest, loss of function. Those are probably more relevant to this audience, who I hope are competent. Almost there. Right. I just wanted to wind up some anaesthetists, so I did. Does the size of the blade make a difference on your first pass success? Again, we're back in FPS. It just is. Nice little trial. It's not the greatest science in the world, but it is interesting actually, because we're talking about marginal gains in how we improve our resuscitation techniques. They looked at 979 intubations, and they observed they weren't using VL, about whether it was seen whether you used a Mach 4 and a Mach 3, whether you got better views and first pass success. And this is relevant, I think, because I have colleagues I work with who say that you can intubate anybody with a size 4. So just always use a size 4 because you know you can do it at Mach 4. Well, I can eat my breakfast with a spade, but I didn't. It is possible. And actually, there's a biomechanically that you could argue that it does make a difference. You've got a smaller blade, and I have kind of changed my practice before I read this study on listening to other people in the area. The results are interesting, actually. It's observational data. It's not an RCT because you can't do it. But when people chose to use a smaller blade, they had better outcomes in terms of view, and they had better outcomes in terms of getting the tube in. Interesting. One to think about. Okay? So yes, you can eat your breakfast with a spade, but don't. Right, couple more. This is controversial because I think this is a really interesting study in that what we've seen is that a lot of services around the world have been pushing for us not to use large BVMs in our patients at the risk of hyperventilation. And clearly you can look at data physiologically that says if we hyperventilate patients, ROSC patients and cardiac arrest patients, hyperventilate them, their outcomes are worse. And that seems to be true. So we said, oh, okay, we can fix that by giving them a smaller bag. I don't think they realise you can just do it faster, but there you go. Actually, that's not what happened. Now, it's not really been RCT'd, but there are areas of the world which have really good data. Seattle, notably. You all know about Seattle's really good data collection around cardiac arrest management. And they looked, so they changed in 2015, and they followed it, changed in 2017. They followed the data from 2015 forward for another few years, and had a look at whether or not their patients had ROSC at the end of EMS care. Now, it's retrospective, it's observational, so lots of other things could have changed during that period, and they did. But what did they find? So they found quite a significant difference. 67% of the patients were treated with a small bag, and they found worse outcomes. So the mortality, the ROSC rate at the end of EMS care had dropped by 7%. That's really interesting. And I'm not going to say much more about this because I know Jason's going to be talking a lot more about airway stuff in the next lecture, and I think he's going to tell me why that is because I don't quite understand it yet. But it's a really good lesson that sometimes observational data post-change is also valuable for us helping to understand what's going on in the world. We need to find an answer for why that is. Notable mentions. Let's see, we've got 3. A nice RCT fairly recently from France looking at comatose patients who said that you don't have to intubate them all if their GCS is low, particularly if they're pissed. Kind of we knew that. But just GCS less than 8 automatic intubate is pretty much, there's lots of evidence now that that's not the case. This is yet another trial in that area. Again, use your judgment, use your thinking, use your words. Nice RCT in New England Journal of Medicine about hypercapnia, or mild hypercapnia versus normocapnia in the post-cardiac arrest patients. It was thought that mild hypercapnia might be advantageous. We recruited to this one. No change, no difference. So put that one to bed for now. And then a good systematic review around the prevalence of severe events, so major adverse events, notably hypoxia, hypotension, and cardiac arrest, the three things I mentioned earlier. Really quite high in the group of patients we see. In their study, it was as high as 30% across all, I think about 34,000 intubations. Again, that's higher than my service, and that's really, really high. And I'm thinking, who's doing this around the world? Hopefully, yeah, good. Right, cardiac is going to be really quick because there's only a couple of really interesting trials. One is DoseVF, RCT of 405 patients looking at refractory VF, which means they've had 3 shocks. And what do we do next? Do we carry on with AP? Do we change it? Do we carry on with anterolateral? Do we go to AP? Or do we go double sequenced defibrillation? So 2 defibrillators, bang, bang. I've been doing it for years on and off. This is the first trial that defends that practice really well. Survival, big differences. So 30% for DSD to hospital discharge, 13% for usual care. And if you looked at neuro, again, the modified Rankin scale with an even higher idea of what the good outcome was, so an outcome of 1 or 2, pretty much going back to normal life, it was DSD which made the difference. Okay, I'm going to leave you with one more trial. I'm going to briefly mention ECMO to say that, I don't know, there's all sorts of stuff going on out there at the moment. We've had 2 big negative trials this year, one about heart failure, didn't seem to work in heart failure, and there was a Netherlands trial of an RCT of ECMO there, which showed no benefit, but quite a few methodological things. I don't know where we are with ECMO at the moment. We're ECMO. I'll wait for you guys to tell me what we should do. And then lastly, I wanted to leave, everything I've spoken about so far is kind of difficult, it's expensive, and it's going to require system change and leadership, and that's going to be hard. So I'll leave you with something which is free. Ever had a love bite? Don't answer that question. So, you know what a Hickey is, or a love bite. There's a really just interesting study, I picked it up from Scott Weingart, which showed that if you want to mark the skin, I use a Sharpie, some people get the end of the needle cap and put it into the skin and try and make a hole, and then you go away and you wash it, so you wash off the Sharpie or you mess about and it's just disappeared. Useful for things like chest drains and lines and things like that, once you've got the drapes on. What they did is they took a 10 ml syringe, you put the 10 ml syringe on the skin, you pull it back 10 mils, you leave it a minute, you take it off. It effectively gives you a little bruise, which of course doesn't go off with cleaning, doesn't go off with ultrasound gel, doesn't go off with anything else, stays there and is absolutely great. And also what they nicely did is they did it across a range of skin types, across the Fitzpatrick scale, and you can see this on all colours of skin. So thank you very much. There is something in this talk which is free, quick and fast, and you can take it away and use it. Thank you very much.
Thank you very much. What a great... Thank you. What a great way to kick off the conference. Do we have any questions from the audience? Can you hear me? It's the first question. I can't see very well with the light in my eyes. Any questions from the audience? Well, I have a question for you. So a couple of those trials are ones that we're going to talk about later in the week. So I don't know if you'd been sort of, breaking into my files to see what other speakers are going to be speaking about. But of all those ones there, which is the one that will have changed your practice the most this year?
DoseVF. So I think that's the one that we can practically do all the time. And as a pre-hospital physician and as an emergency physician, the patients I see in VF are usually already in refractory VF because somebody else has been at the scene first or they've brought the patient to hospital. They've already shocked them 3 times. So my attitude and my sort of approach to, if I hear we're going to a patient with a VF or a patient with VF is coming in, I'm thinking, actually, where are we down that algorithm? Now, and it's not in all the guidelines as yet, but I think that's the one that's made the biggest difference in practice. And anecdotally, I've had some success, and I'll be interested to hear over the next few days whether other people have done as well.
Does anyone here do DCD? Down there? And what are your experiences with it? Oh, sorry. Thank you. Have you encountered much resistance? Because I know...
I've encountered some resistance, yeah.
Yeah, because I know initially when it came out, there was a lot on sort of social media and sort of chat sites about people poo-pooing it or going for it completely, and sort of quite polarizing as a topic.
Yeah, so there is resistance to it because it's not necessarily in the guidelines as yet. But again, when we're getting involved, and when I say we, the group of people here, we're generally accessing the patients in cardiac arrest at the point where the usual stuff has failed. So people have done the stuff that they should be doing. Our local ambulance service is really good at running arrests according to the ALS guidelines. I don't have any problem with that. We're getting to the patient when that hasn't worked. And so if we're going along and we're just doing the same, oddly enough, it doesn't usually work. We have to be thinking about what we're doing differently and taking the care onto a higher level. So that is things like putting art lines in and looking what their diastolics are, getting those to the right problem, maybe getting adrenaline by infusion rather than by intermittent boluses, looking at DSD. And again, we can talk about human factors, but when we do arrests with the ambulance service, they usually carry on doing the arrest. They're doing the operational cycle stuff. What we're doing is strategy and intervention, which is focused and targeted to what we think the underlying problem is. That's what we can contribute, and that's what I think we can do. Don't take over the arrest. The people who are running the arrest are paramedics. They do it really well, and we can do similar things in hospital. There's so much going on in a complicated arrest. You don't have enough bandwidth to run it and also to work out what's going on and where we're going next. So make it easy. And this is a theme that's been around for a while, but yeah, putting it into practice can be a bit tricky.
Fantastic. Thank you so much.